My name is Brian Wood, Medical Director for the Mountain West AETC ECHO. Welcome to this week's session, and I will turn it over to today's speaker.
I am the first of 5 talks that you're going to have on CROI. Julie Dombrowski is going to tell you about prevention in general, and I have picked some PrEP-related topics that I thought were very interesting that are not the ones that Julie is going to tell you about. So what I thought was really interesting, there was nothing really groundbreaking from my perspective about what happened on PrEP, but there's a lot of information about sort of tweaking, about implementing what we have on daily tenofovir emtricitabine. I am really interested in the future of TAF, so I'm going to tell you a little bit about what data came out from there. And then we're going to talk a little bit about alternate dosing strategies other than daily dosing. There were several presentations about who is missing from the PrEP prescriptions, several by Don Smith from CDC, and this first poster that I'm going to share with you is from CDC's Medical Monitoring Project, which, as I'm sure you all know as HIV providers, selects HIV-positive individuals for interviews and chart reviews. This project was done in a few years ago, something important to note, 2014 to 2015, and they were interested in looking at PrEP uptake among the positive partners. So of the people who are being evaluated as part of MMP, they asked about the 5 sexual partners, and they are interested in the PrEP uptake among negative partners of the people they're doing chart reviews. So the other caveat is that this is information being gleaned from the positive partner. So of the 918 men who have sex with men who had chart reviews, they got information on 1,900 HIV negative partners, and of those, the positive person reported that 6% of their partners were on PrEP. But we know that HIV treatment decreases the risk of transmission. So really what we're interested in is PrEP use among the partners of patients who are not suppressed. And so of the total number of partners, 67% of them were not taking PrEP, but the patient had a suppressed viral load. But interestingly, 27% of these total partners were not taking PrEP and the patient was not suppressed. Overall PrEP use, this is not surprising. This is a theme that came out over and over. PrEP use was associated with race and ethnicity. So of all the partners reported, 4% of the Black and African American partners were on PrEP, 5% of the Hispanic Latino partners were on PrEP, compared to 8% of the white Caucasian partners. And then focusing now on the partners of patients who are not virally suppressed. So overall, and this is sort of backwards thinking, this is the partners who are not taking PrEP, 29% of them were of HIV positive patients who were not virally suppressed. So 29% is what you should be thinking about as your average. And what you can see here is that it is significant by age. So fewer of the under 29-year-olds had partners, more of the under 29-year-olds had partners that were not suppressed, 34%, compared to folks who were in the older age ranges. Fewer of them had partners who were not suppressed. Again, looking at race ethnicity, if you were a partner who was Black or African American, 42% of the HIV positive partners were not suppressed. And also not surprisingly, if you were having condomless receptive anal intercourse, CRAI, that fewer of your partners were not suppressed. So people who were having partners who were suppressed, fewer of them were using PrEP. This is always getting sort of back and forth to me. So it was, people were assessing risk and were more likely to have a partner who was suppressed and were not using condoms. So conclusions of this paper, reported PrEP use, again, 2014 to 2015, of men who have sex with men who were HIV patients, that was low. Black partners of these patients were less likely to be using PrEP, and younger and Black partners not taking PrEP were more likely to be the partner of a patient who is not virally suppressed. Again, it's sort of a denominator that's not quite logical, but this may contribute to disproportionate HIV incidence, is one of the reasons why we suspect that certain populations are at greater risk for HIV despite not having real differences in their sexual risk. Take-home point for you all. Again, this is a couple years old, and so much of these numbers are hopefully going to increase as PrEP use has increased over the last few years, but please consider asking your HIV-positive patients who are not, particularly those who are not suppressed, about their partners and providing your patients information to assist those HIV-negative partners who are not on PrEP and accessing PrEP. If you want to learn more about racial disparities, Don Smith from the CDC gave a really nice oral presentation, and I've included the link to that, so you should hopefully just be able to plug that in and start listening. There were also a really nice set of abstracts from San Francisco trying to identify who was not on PrEP using medical records. And this is something that we've been really thinking about how to do here within the UW system. And I would encourage many of you all to think about this in your practice, trying to figure out not only who is on PrEP, but who is not on PrEP and should be. And so the abstract which is a poster that I'm going to talk about in the next few minutes, is from the San Francisco Department of Public Health Primary Care Clinics, so a network of clinics, and there's a really nice map on their poster if you want to look at that to show the distribution of these clinics in San Francisco. And they were trying to identify PrEP candidates. For those of us who've been thinking about this, the people we think of as sort of the lowest hanging fruit are the people with syphilis or the people with rectal STDs. But sort of how do we expand beyond that to include many other people at risk? And so what they defined is someone who is HIV negative and not on PrEP. So they looked and tried to identify everybody who is on PrEP within their system. And then anybody, male or female, who had been screened for rectal sexually transmitted infection. Anyone who was diagnosed with syphilis in the last year. Interestingly, I hadn't thought of doing this, anyone who had received at least 3 HIV tests in the last 2 years, thinking that this is a really good marker for someone who is probably at risk for HIV. And so within their, I don't remember what their total of number of patients within their system was, 451 were receiving PrEP within their system, and an additional 2,100 they defined as high risk according to these criteria. And if you're interested in sort of quality of care and trying to figure out how we're doing with getting STDs and HIV testing and creatinine clearance and other things related to PrEP quality, there is a related poster from these same authors that is poster number 1028. But what I'm going to show you here are the adjusted odds ratio of not being on PrEP among those identified as being high risk. And so from theirs, they identified that being female at birth was associated with an adjusted odds ratio of over 5 among those who were identified as being high risk. And then being of older age, over 50, was actually associated with not being on PrEP. And then again, race, ethnicity, both Latinos and Black African Americans were less likely to be on PrEP, more likely to not be on PrEP. And then finally, they adjusted for whether or not people had been in care and had a primary care visit. And so obviously people who had seen a primary care provider in the last couple of years were more likely to be on PrEP. They had a couple explanations for this. The female at birth may just be that it's really challenging for us to figure out exactly who is a cisgendered woman and likely to be at risk for HIV, and so harder to prescribe PrEP, whereas we all have been focusing on men of sex with men. The authors suggested that the folks who were over 50 were less likely to be on PrEP because they were more likely to be using other prevention strategies such as condoms, which is not included in here as sort of a marker. And then, of course, again, the findings from all of these presentations, as well as our own experience, that Latinos and African Americans less likely to be on PrEP. This is the only information moving on, the only information related to FTC TAF, which is, of course, Descovy, which we are interested in to see whether or not it's going to be effective as PrEP. This is the only abstract that touched on this, but I just wanted to bring it forward because we have a limited amount of information on this. So this project was oral FTC TAF in combination prevents vaginal SHIV, simian HIV infection in pigtail macaques. And so as background, we know FTC tenofovir disoproxil fumarate is the only combination product that is currently approved because it is the only product that has been proven to reduce a person's risk of HIV. And while Descovy has been approved for treatment, it has not yet been proven to be effective in keeping an HIV negative person from becoming infected. We've talked about the fact in the past that this Discover trial is ongoing to try to answer this question. It is a 92-site international trial enrolling 5,000 cisgendered men and transgender women, randomized either 1-to-1 to active Truvada plus Descovy placebo versus active Descovy plus Truvada placebo. It is currently closed to recruitment, and study completion is anticipated in a year. which means we only have a year, but we still have a year to wait for these results. And we know that Descovy protects against rectal transmission in macaque model, and this was presented at CROI a couple years ago and published in Journal of Infectious Diseases. And in that studies, there were 6 macaques in each of the 2 groups, placebo versus Descovy, and all of the placebo macaques became infected and none of the actively treated controls. And this is what we have so far. And so this was looking at vaginal HIV infection. They used the same exact exposure model, obviously as vaginal instead of rectal, as they used in the past. They had pigtail macaques that were having regular menstrual cycles, and they administered what they believe is an equivalent dose by gavage. I learned a new word. So basically oral administration, 24 hours before and 2 hours after weekly exposure to HIV. So not exactly daily PrEP use, but this is the model that they've used in the past. And what you can see here is in the red line that all of the control macaques became infected over time, and there was 1 active arm macaque out of, it was 8, who became infected over the course with an efficacy of 82% protection in this model. So some additional evidence that Descovy may be effective in women having vaginal exposure, but again, too early to recommend this. We need to wait for the Discover trial. They looked at levels of the metabolites of tenofovir and FTC during these challenges to see in the infected macaque what her levels would be. And they did this, I'm going to apologize, I didn't mess with these slides, so this is directly from the poster. This is the tenofovir levels over here and the summary of the tenofovir levels on the right, and then the summary of the FTC levels here in PBMCs and the summary on the right. And so what you can see, we'll start with tenofovir first. This is the infected macaque in red. That the infected macaque had effectively undetectable levels of tenofovir in PBMCs. She became infected very early. So undetectable levels, but her FTC levels in PBMC were quite high. And so I think there's some concern with Descovy because it gets different levels in different places than with Truvada that may not be effective. And so I think the conclusions here that FTC TAF prevented HIV in a similar degree compared to Truvada, and that TAF likely contributes to some protection because the infection occurred only in the 1 macaque who had low tenofovir concentrations. And these authors are suggesting that this supports evaluation of Descovy for PrEP against vaginal infection in women. So that might be something that we see future on. And then finally, in my last couple minutes, I just want to bring us back to non-daily dosing. I've talked several times about IPERGAY because I just find it fascinating. And so just to remind you, IPERGAY was a study that was done looking at intermittent or on-demand dosing. The recommendation was that 2 to 24 hours before you have sex that you take 2, again, we're going to go back to Truvada. So 2 Truvada pills before having sex, take 1 tablet 24 hours later, take 1 tablet 2 days later. And this is the modified intent to treat analysis that published several years ago, showing an 86% relative reduction in this strategy compared to placebo. When they've looked at it, the people who were in the active arm weren't actually taking Truvada at the time, but some evidence suggesting that a on-demand strategy may work for individuals who are able to predict when they are going to have sex. Shown you sort of the data on men have sex with men and the likelihood of knowing when they're going to have sex, and that's another topic for discussion. But what in the IPERGAY trial, as it moved to open label, what they wanted to do was try to get a sense of how many sex acts were covered adequately by taking on-demand PrEP compared to daily PrEP. If people are taking PrEP every day and they're adequately taking it every day, all of these events are going to be covered. But if people are taking it intermittently, we know from their sub-analysis that I presented, I think a year ago, that efficacy was just as high as in the daily group, but wanted to drill this down and understand sort of how well people were doing in predicting when they were going to have sex. So they did a sub-study in the open label extension, so everybody on active drug, between March and May of 2016. People use MEMS caps, which are basically, as you can see from the image, a pill bottle that has a electronic sensor. You have to interrogate the sensor. It can't transmit information in real time, but it can collect information on pill bottle openings, presuming that you take your pill at the time of opening it. People also completed a daily CASI, asking them whether they had sex, what they did during sex, and how long the sex lasted. participants' dichotomy. It's important to know that this was not randomized. So they considered based on whether people took their pills 5 or more days a week versus less than 5 days a week. They called them daily users if they took 5 or more, or intermittent if they took that less than that. So people weren't randomized to being an intermittent user versus a daily user. And they considered coverage for the event if you took either 1 or 2 pills within 24 hours before and at least 1 Truvada pill within 48 hours after having sex. So a little bit different than what they considered their protocol to be, because people were having sex multiple times a week, and it's hard to separate if people are having multiple times a week whether or not things are covered unless you are a little bit more liberal. Partial coverage was either one of these, and no coverage, no Truvada pills within 24 hours before or 48 hours after sex. This is just to give you an idea of the number of times people were having sex and the number of times people were opening the 2 arms. Overall, people were having sex not quite 4 times a month, about once a week, and the average time that they were opening bottles was about every other day. In the intermittent group, again, not people self-selected into these, people were having sex on average 2.5 times a month and opening their bottles about every 3rd day. And in the daily group, they were having more sex sessions, again, about 2 times a week, and opening their bottles about 6 times a week. But again, not randomized, so you expect to see these numbers. They did a comparison between these 2 groups, which I'm not sure is totally valid, but really what I want you to focus on is the half on the right, which shows the people who were defined as intermittent users. And the dark blue at the bottom is full coverage, again, a pill before, 1 to 2 pills before, and at least 1 pill after. Partial coverage, again, being one of the other, and the white bars at the top being no coverage. The thing, number 1, is that, and their abbreviations are slightly different, I don't know if this is the French, but this is condomless receptive anal intercourse. It's receptive anal intercourse without a condom is what their definition is. And 82% of these events were fully covered. And the other interesting thing to see is that people were appropriate about taking their Truvada based on what they were doing. So reporting oral sex was much less likely to have full coverage, and then any anal sex goes up, and anal sex without a condom, this is any anal sex, and this is receptive anal intercourse. So people were appropriately using their on-demand PrEP. And this, I think, is my last slide. So conclusions of this. So PrEP coverage of these sessions was high. 82% of sessions where condomless receptive anal sex happened was covered by this on-demand PrEP. Coverage of sessions increased with at-risk practices and was highest, appropriately, that is my editorial, for condomless receptive anal intercourse. My caveat, of course, is PrEP is not currently FDA approved for anything other than daily use. And for those of you who are interested in, and we talk about this in cases in the past, there was another poster that's on 1035 that was looking at basically PrEP for vacations. So people doing a ramp-up phase before going on a vacation where they anticipated high-risk activity to occur, and then the tail-off phase. And there were no infections that occurred during this time. So if you are interested in that, please look at that poster, and I'm done.